You know that feeling when you narrowly avoid a car accident?
Oh, absolutely.
Your hands are just gripped to the steering wheel, your heart is suddenly pounding in your ears, and your breath catches. We all know that feeling of psychological stress.
Right.
But if we, peel back the layers and look at what is happening biologically, there is this incredible silent machinery keeping you alive in that exact fraction of a second.
And it is entirely invisible to us. Because while we are busy reacting to the road, the body is mounting a massive physiological response. It is rapidly deploying chemical resources like spiking your blood sugar for immediate energy.
Constricting your blood vessels to keep your blood pressure up.
Exactly, all so you can survive the crisis.
Okay, let's unpack this. Because to answer how that actually works, we are pulling from a stack of medical history, modern clinical case studies, and endocrine pathophysiology. In this deep dive, we are looking at the ultimate biological stress bank that funds your survival response, which is the adrenal glands. Because to truly understand how the body manages a crisis, you really have to look at what happens when that stress bank goes utterly bankrupt. Which brings us to Addison's disease.
Right, and with Addison's, we are looking at a profound failure of a very specific system. It's classified as primary adrenal insufficiency.
And that word primary carries a lot of clinical weight, right?
It really does. It means the failure is happening locally at the adrenal glands themselves, rather than a failure higher up in the brain's command chain.
To see why this disease is so devastating, you have to realize the adrenal gland isn't just one monolithic factory. We are talking about two walnut-sized glands sitting right on top of your kidneys. But the issue in Addison's is restricted to the outer rind, the adrenal cortex.
Yeah, and that cortex is actually 3 separate factories stacked on top of each other.
Like the rings of a target.
Like the rings of a target, exactly. And the architecture dictates the symptoms. So if we start on the outermost edge, you have the zona glomerulosa. This ring manufactures a hormone called aldosterone. Aldosterone is the master regulator of your blood volume and blood pressure. It functions by giving very specific instructions to your kidneys, which are basically hold on to sodium and flush out potassium.
Which makes sense from a basic biology standpoint because water follows salt.
Right.
If the kidneys hold on to sodium, they hold on to water, which keeps the total volume of fluid in your blood vessels high, keeping your blood pressure stable.
You've got it. And then, stepping one ring deeper, we hit the zona fasciculata. This is the big one.
The cortisol factory.
Yes, it's the factory for cortisol, your body's primary stress hormone. We often hear cortisol and associate it with negative things like, feeling burned out at work.
Yeah, cortisol gets a bad rap in the wellness space.
It really does. But biologically, it is non-negotiable for life. I mean, it triggers your liver to manufacture new sugar from scratch so that you have energy in a crisis. It allows your blood vessels to maintain their tone.
It suppresses rampant inflammation.
Exactly. And it runs on a strict daily rhythm. It peaks right before you wake up to give you the energy to start the day, and it drops to its lowest point around midnight.
So when your alarm goes off at 7 in the morning and you actually find the energy to get out of bed, you have that middle ring of the adrenal cortex to think.
Yep.
Now, what about the bullseye of our target?
The innermost ring is the zona reticularis, which produces adrenal androgens, these sort of minor sex hormones.
Minor compared to the ovaries and testes, right?
Right. While the ovaries and testes supply the vast bulk of sex hormones overall, these adrenal androgens are a crucial part of the layered factory, particularly for maintaining things like pubic and underarm hair in women.
I want to build on that primary versus secondary distinction you brought up earlier because the medical texts lean heavily on it to explain the cascading symptoms.
Yeah, it's a huge distinction.
So if the brain, specifically the hypothalamus and pituitary, is sending the chemical signals to produce these hormones, let's call the brain the thermostat.
Which would make the adrenal gland itself the furnace.
Right. So in a secondary issue, the thermostat is just broken. It's not sending the signal asking for heat.
But the furnace works fine. It's just waiting for instructions.
Exactly. But Addison's primary insufficiency is when the thermostat is working perfectly. It's screaming for heat, but the furnace has burned to the ground.
That's a great way to look at it. And because that furnace is completely gone, the patient loses everything at once. You don't just lose cortisol, you lose all 3 products from those target rings simultaneously.
So the blood pressure crashes.
Right, because they've lost aldosterone and their kidneys are just dumping sodium. They have severe low blood sugar and no ability to handle physical stress because the cortisol is gone.
And they might be losing body hair because of the missing androgens.
Exactly.
The sources paint a picture of a really slow, agonizing decline. Like people are walking around for months, even years, just feeling terribly unwell. If this vital organ is essentially burning down, I kept wondering how it takes so long for anyone to notice.
Well, it comes down to the sheer elasticity of the human body's reserve capacity. The adrenal cortex is wildly over-engineered.
How so?
The clinical data shows that roughly 90% of the adrenal cortex must be destroyed before overt symptoms of insufficiency even appear.
Wait, 90%? You can lose almost the entire organ before your body raises a red flag.
Yeah, it's pretty incredible.
I want to know the mechanism there. How does the body compensate for losing that much of a vital organ without showing it?
The remaining cells undergo cellular hypertrophy.
Meaning they get bigger.
Exactly. They physically enlarge and work exponentially harder.
Yeah.
As the disease destroys part of the gland, the surviving cells ramp up their individual production to keep the overall hormone output completely normal.
Oh, wow.
Imagine a factory where 90% of the workers suddenly quit. The remaining 10% just pull back-to-back shifts to meet the exact same quota.
So you wouldn't notice a drop in the factory's output until those final few workers literally collapse from exhaustion.
Precisely. And that explains the clinical iceberg.
Mm.
Most of the disease's progression is hidden underwater. You're cruising along the highway with 10% of an engine.
And as that destruction finally creeps past 85, 90%, the compensation fails.
Right. You get this gradual onset of incredibly vague symptoms. Profound fatigue, unexplained weight loss, dizziness when standing up because the blood pressure is dropping.
The text mentioned they might also develop an intense craving for salt.
Yeah, they're trying to manually replace the sodium their kidneys are flushing away.
But the profound danger of that iceberg is what happens when the patient finally hits it, right? Because of the vague nature of fatigue and weight loss, these patients rarely get diagnosed during the slow creep.
Unfortunately, no. They get diagnosed when the final few factory workers collapse all at once, in what's known as an acute Addisonian crisis.
Which I was shocked to read is often triggered by something incredibly mundane, like a stomach bug, a minor infection, or a routine surgery.
Because that everyday physical stressor demands a massive surge of cortisol just to keep the cardiovascular system stable. But the bank account is utterly empty.
So the patient goes into profound shock.
They do. Their blood pressure bottoms out. They experience severe vomiting and abdominal pain that can be so intense it actually mimics a surgical emergency like a ruptured appendix.
Wow.
And without immediate intravenous steroids and fluids, the cardiovascular system simply stops.
The sources bring up a terrifying parallel to this called Waterhouse-Friderichsen syndrome. It's described as the acute mirror image of Addison's, because in Addison's, the destruction usually takes months or years.
Right.
But in Waterhouse-Friderichsen syndrome, the adrenal glands are wiped out in a matter of hours.
A totally healthy person can go into catastrophic circulatory collapse within a single day.
So Waterhouse-Friderichsen compresses the vulnerability of Addison's from years into just hours.
Exactly. The trigger is typically a fulminant infection, classically a bacteria called Neisseria meningitidis, which enters the bloodstream and causes meningococcemia. The infection is so overwhelming that it triggers septic shock and something called disseminated intravascular coagulation, or DIC.
I had to stop and read up on DIC because the terminology is incredibly dense. Essentially, the body's blood clotting system panics, right?
Yeah.
It starts forming microscopic clots everywhere inside the vessels all at once.
Which is disastrous for an organ as highly vascularized as the adrenal gland. When the blood supply gets blocked by all those tiny clots, the blood vessels burst. Both adrenal glands hemorrhage.
Oh, man.
They bleed out and suffer tissue death overnight. It proves just how tightly our minute-to-minute survival depends on the adrenal cortex. When the stress bank is emptied, whether slowly by autoimmune destruction or overnight by a hemorrhage, the body simply cannot compensate.
Since Addison's disease is this hidden iceberg, clinicians obviously need clues to spot it before that subtle crisis hits. And here's where it gets really interesting. The most famous physical marker of this disease is right there on the outside of the body.
The hyperpigmentation.
Yeah. Can you explain why failing adrenals turn the skin bronze?
The mechanism behind the skin bronzing is one of the most elegant pieces of pathophysiology in all of endocrinology.
I love how the sources describe this.
It's fascinating. So to understand it, we look back at our thermostat, the brain. Normally, cortisol acts as a brake on the brain signaling. It tells the hypothalamus and pituitary, we have enough stress hormone circulating, you can stop sending the signal.
That is a classic negative feedback loop.
Exactly. But in Addison's, the funness is gone. There is no cortisol to pump the brakes.
So the pituitary gland just starts desperately trying to get the adrenals to wake up.
Right. It cranks out massive amounts of its signaling hormone, ACTH. But the pituitary doesn't just make ACTH out of thin air. It has to snip it out of a much larger precursor protein.
The sources call this precursor protein POMC, propiomyelanocortin.
Try saying that 3 times fast. But yes, the pituitary manufactures tons of POMC to generate enough ACTH to shout at the failing adrenal glands. But when you snip ACTH out of POMC, you are left with several biological byproducts. One of those byproducts is MSH, melanocyte-stimulating hormone.
And as the name suggests, it overstimulates the melanocytes, the pigment cells in the skin.
It causes a distinct bronzing or darkening. It is usually most visible in areas exposed to friction or pressure, like skin creases, scars, knuckles, elbows, and even inside the mouth on the mucous membranes of the gums.
But this mechanism provides a crucial diagnostic divider, right? This bronzing only happens in primary adrenal insufficiency.
In Addison's, yes, because that's the only scenario where the brain is desperately shouting and overproducing POMC.
So if you have a patient with low cortisol who is pale,
That points to a totally different problem. A pale patient with low cortisol points upstream to the pituitary. That is secondary insufficiency. The brain's thermostat is broken and isn't sending the signal,
so POMC and ACTH are low.
meaning MSH is low.
So there's no hyperpigmentation. The skin color literally tells you where the failure is occurring in the body.
It's a built-in diagnostic test.
We can't talk about this bronzing effect without looking at the most famous case of Addison's disease in modern history, which is John F. Kennedy.
Right.
He was diagnosed in London in 1947 when he was just 30 years old.
His case completely inverts the popular narrative of illness.
It really does. The famous Kennedy tan, which the public and the media heavily interpreted as a marker of youthful vigor, outdoorsiness, and health,
Was actually the hyperpigmentation from his Addison's disease. The visible marker of a life-threatening illness was read by the entire world as a sign of supreme vitality.
And staying strictly to the historical record of how his campaign handled this, during the 1960 presidential race, his opponent's team tried to use rumors of his Addison's disease as evidence of physical frailty.
In the high-stakes political environment of the mid-20th century, a chronic, potentially fatal illness was seen as a massive electoral liability.
Right, and Kennedy's campaign issues statements saying he did not have classic Addison's disease caused by tuberculosis.
Which was technically a true statement.
It was. But it artfully parsed definitions to dodge the reality that he had the autoimmune form of the exact same disease.
And the campaign's reliance on the distinction between tuberculosis-caused and autoimmune-caused perfectly illustrates the massive etiological shift in Addison's disease over the centuries.
Let's trace that shift, actually, because Thomas Addison, the meticulous London physician who first described this in 1855, was looking at a very different clinical picture.
He was. Thomas Addison was known in London as the doctor's doctor, incredibly rigorous and observant. In his 1855 monograph, he described 11 patients who had wasted away with that progressive weakness, gastrointestinal upset, and the strange bronzing of the skin.
And when he performed autopsies, he found their adrenal glands were completely riddled with disease.
Right. In his era, that disease was almost always tuberculosis. The TB bacteria would spread through the bloodstream, lodge in the adrenal tissue, and physically destroy it.
But the fascinating part is that Thomas Addison didn't actually know why destroying these little glands killed his patients.
No, he didn't. In 1855, the medical consensus was that the adrenals were just vestigial quirks of anatomy, like the appendix, doing nothing of importance.
So Addison provided the clinical description, but the biological mechanism arrived a year later in 1856.
Yes, from a French physiologist named Charles-Édouard Brown-Séquard. He surgically removed the adrenal glands from laboratory animals, and the animals died within days from profound circulatory shock and sodium loss.
So it was a perfect historical sequence. Addison observed the failure at the bedside, and Brown-Séquard proved its necessity in the lab.
The adrenals were absolutely essential for maintaining the cardiovascular system.
But fast forward to today, if a doctor in London or New York is diagnosing a patient, it's rarely tuberculosis anymore.
No, in wealthy countries today, the dominant cause is autoimmune. The patient's own immune system misidentifies a specific enzyme in the adrenal cortex as a foreign threat and generates antibodies to attack it.
The enzyme is called 21-hydroxylase.
Right. And 21-hydroxylase is an essential worker on the cellular assembly line. It is required to manufacture both cortisol and aldosterone. So as the immune system slowly destroys this specific enzyme, the factory crumbles from the inside out.
The sources are careful to note, though, that in regions where tuberculosis is still endemic, TB remains a leading cause of Addison's.
Yeah, the exact same clinical syndrome has entirely different underlying causes depending on where in the world you live.
Which fundamentally dictates how a doctor investigates the illness.
Exactly. In a low TB region, you screen a new Addison's patient for 21-hydroxylase antibodies right away. In a high TB region, you prioritize imaging, looking for calcifications in the glands or signs of an active infection.
The text also points out that autoimmune Addison's doesn't always act alone.
No, it often travels in packs. It fits into a wider web of autoimmune diseases. We see this in autoimmune polyglandular syndromes, or APS.
What does that look like?
Well, in APS type 2, for example, a patient might have autoimmune Addison's paired with autoimmune thyroid disease or type 1 diabetes. The immune system is systematically targeting multiple different endocrine glands across the body.
Since we're talking about causes and modern diagnoses, there is a major point of friction in the wellness space that we really need to address.
Oh, well, I know where you're going with this.
You see the term adrenal fatigue everywhere online. The popular idea is that the chronic stress of modern life, the emails, the lack of sleep, the emotional burnout, basically wears out your adrenal glands until they can't produce enough cortisol anymore.
Yeah,
But the medical sources are incredibly firm on this.
they are unequivocal. Adrenal fatigue is not a recognized diagnosis in mainstream endocrinology. There is zero clinical evidence that everyday psychological or lifestyle stress causes measurable adrenal underperformance in people with a normally functioning command chain.
So the stress of a terrible commute or a demanding boss doesn't drain the biological battery.
It does not. The adrenal glands do not just get tired from a stressful lifestyle. They fail because they are being physically obliterated by an autoimmune attack, an aggressive infection, a hemorrhage, or a genetic defect.
And this isn't just doctors being rigid about terminology, is it? It's an issue of patient safety.
It is incredibly dangerous. When a patient is marketed unproven adrenal support supplements for a fake condition, it delays the diagnosis of what's actually causing their profound fatigue.
Which could be anything.
Right. Maybe it is early-stage Addison's disease, and they are unknowingly creeping toward a fatal crisis. Or maybe it's severe anemia, undiagnosed heart failure, or clinical depression. Self-treating a non-existent mechanism guarantees you are ignoring the very real underlying pathology.
Which brings up another major misconception mentioned in the text, the fear of steroids. When people hear the word steroids, they immediately think of bodybuilders, anabolic steroid abuse, and dangerous side effects.
Yeah.
So when a newly diagnosed Addison's patient is told they need to take steroids every day for the rest of their life, there is understandably some panic.
And that panic stems from fundamentally misunderstanding the goal of the treatment. In Addison's disease, the treatment is physiologic replacement, not superphysiologic abuse.
We are just refilling the tank to its normal baseline.
Exactly. When you treat Addison's, you prescribe corticosteroids. Usually that means hydrocortisone to replace the missing cortisol and fludrocortisone to replace the missing aldosterone.
Okay.
You're giving the body the exact milligram amount of hormone it would normally make on its own on a calm Tuesday. You are simply restoring the baseline that the burn-down factory can no longer provide.
That makes total sense.
Anabolic steroid misuse involves taking synthetic hormones in quantities vastly exceeding what human biology ever intended. The clinical goals and the safety profiles could not be more different.
I did struggle with one part of the clinical sources, though, regarding how doctors actually diagnose this. They use the cosentropin stimulation test where they inject you with synthetic ACTH to see if your adrenals respond.
Yeah, the stimulation test.
If we have a synthetic version of the exact signal the brain uses, shouldn't this be a simple pass-fail? Why is the medical community still debating how to read this test?
You would absolutely think it would be a clear pass-fail, but biology loves a gray area. The debate centers on the dose of the injection and the diagnostic threshold. When you inject that synthetic ACTH, you measure the cortisol output 30 or 60 minutes later.
Right.
Clinicians have argued for decades over what post-stimulation number constitutes a healthy response versus early failure.
Is that because of the 90% reserve capacity we talked about earlier?
Exactly that. In early or partial adrenal insufficiency, a patient might have just enough reserve left to eke out a passing grade on a standard high-dose stimulation test.
Ah, I see.
The high dose essentially forces the failing gland to perform one last time, giving the doctor a false sense of security, even though the patient is highly symptomatic in their daily life.
So the test looks fine, but the patient is actually in trouble.
Right. This has led to intense debates about using low-dose stimulation tests. A low dose is much more sensitive for catching borderline cases before they hit the crisis point, but it's much harder to standardize across different laboratories.
So what does this all mean? If we pull back from the molecular details and the diagnostic debates, what does Addison's disease ultimately teach us?
It is the ultimate paradigm for how reserve capacity can mask organ failure. A human body can compensate for an astonishing amount of internal destruction completely silently, right up until the moment a stressor demands that reserve.
Right.
It proves that surviving a physical crisis isn't just about the crisis itself. It's about the biological savings account you have in reserve before the crisis even hits.
And for patients living with Addison's today, managing that savings account is a literal daily reality. The sources describe these sick day rules. Because they have no biological ability to surge cortisol during a physical stressor, they have to calculate it manually. Imagine getting the flu, or having to undergo a dental surgery and having to manually double or triple your oral steroid doses to artificially mimic what a healthy adrenal gland would do on autopilot.
They're manually operating their own stress response. It is why they're advised to wear medical alert bracelets and carry emergency injectable hydrocortisone kits everywhere they go.
Because if that crisis hits,
The windows for survival is measured in hours.
it is a profound responsibility to carry. But it's also a stunning testament to medical progress. Think about the historical arc we've traced. In 1855, Thomas Addison describes a grim, unexplained death sentence.
Right.
In 1856, Brown-Séquard proves the adrenals are essential for cardiovascular survival. But it wasn't until 1949 that cortisone was first synthesized and used as a therapeutic pill.
Nearly a century of understanding the disease without being able to stop it. The synthesis of cortisone turned a universally fatal diagnosis into a manageable chronic illness. It was such a monumental leap that the researchers won the Nobel Prize in Medicine the very next year, in 1950.
It's a perfect encapsulation of the gap between describing a disease and actually curing it. As we wrap up this deep dive into the body's ultimate stress bank, I want to leave you with a thought drawn from that history, specifically the Kennedy case. We talked about how Kennedy's team concealed the full nature of his Addison's disease, allowing the public to interpret the bronzing of his skin as a sign of vigorous health, rather than a symptom of a precarious hormonal balance.
Yeah.
It raises enduring questions about leadership and disclosure that resurface every election cycle. When a leader's body literally lacks the biological reserve to handle acute physical stress, when their internal factory has burned down and they are reliant on manual replacement just to survive a common infection, where's the line between personal medical privacy and the public's right to know? If the biology of stress is the biology of survival, who gets to know how much is left in the bank?